I think we can look at this part of the spectrum of GI cancer treatment as early detection of cancer or early/faster diagnosis of cancer. So I talked about studies and evidence for liquid biopsies, specifically ctDNA in both, and the different techniques. So I think when we look at ctDNA for this indication, it's plasma only because we're not using the tumor to guide us. So sensitivity is important, and there's various technologies which might leverage whole genomic approaches, methylation approaches, something called fragmentomics, a mixture of the above. And many of the tests and the studies we see are multi-analyte, so they're leveraging these different characteristics to see if we can really detect cancer before it's symptomatic, so early detection. And I've presented a number of studies that are running. Some of them are linked to, say, colorectal screening programs. Some of them are looking at asymptomatic general population screening. Very ambitious study in the UK with the GRAIL test of 140,000 asymptomatic people aged 50 to 77, currently running to see if that dries up earlier detection, stage 1 and 2, where we know treatment is more curable and that survival will be better, and that is a key aim. And for me, in the diagnostic space, this is something I'm very interested in. I think a sharp focus shone on it by the COVID pandemic, when diagnostic capacity for GI cancers reduced. And again, with a number of these different assays, we see potential clinical utility in the early diagnosis space, i.e. patients presenting with symptoms. Can we get to the diagnosis more quickly, more efficiently? Again, get patients onto treatment more quickly. And from my institution, we presented a small pilot study, again, precipitated by the pandemic, deploying liquid biopsies for a faster diagnosis in HPV cancers.